Bonjour tout le monde, merci de votre présence. Je débute par me présenter, Simon Rousseau. Je suis professeur et chercheur à l'Université McGill et à l'Institut de recherche du CUSUM. Je suis aussi co-directeur de la biobanque québécoise de la COVID-19 et directeur de la biobanque du Réseau en santé respiratoire du Québec. Je voudrais vous remercier d'être présent. Je veux remercier l'auditoire de se joindre à nous ce matin. J'en profite aussi pour remercier le RQCP pour avoir organisé cette grande conférence et nous permettre d'échanger aujourd'hui. L'atelier va se dérouler en 3 phases. Une première phase où chacun de nos invités vont se présenter. Donc, on a la chance d'être joints par des invités qui viennent de la province, du pays, mais de l'international pour discuter du rôle des biobanques durant la pandémie. Et ils vont donc se présenter brièvement. Ensuite, chacun aura la chance de s'exprimer sur le sujet qu'on a choisi pour cet atelier, qui est à savoir quels sont le rôle des biobanques dans la pandémie, et surtout pour informer les instances de santé publique. Et par après, on va ouvrir le plancher pour discussion. Donc, j'invite les membres de l'auditoire qui ont des questions à simplement lever votre main et je vous donnerai la parole lorsque je vois votre nom apparaître. Si certains d'entre vous êtes trop gênés pour prendre la parole, vous pouvez toujours taper vos questions dans le chat et j'essaierai de modérer le chat, mais la préférence serait de faire les questions à main levée. Je tiens à mentionner que l'atelier va se dérouler en anglais et à partir de maintenant, je vais changer à l'anglais. Donc, good morning, everyone. And I will not repeat what I've just said in French, but we'll go ahead with our speaker's introduction, just to briefly outline that today we're tackling what are the role of biobanks in a pandemic. So we know quite well how they can support research, be it basic or fundamental research in a non-pandemic time, but do they play the same role? Can they play additional roles? And also, can they inform public health policies? So these are the questions we're looking at tackling this morning. This will be an interactive workshop, and we are very lucky to be joined by an expert panel from that is provincial, national, and international. And without further ado, I'll ask each member to introduce them, and I'll call out your name. So we'll first start with Angela Chong.
Hi, thank you for inviting me to this panel discussion. I am a professor of medicine at University of Toronto and a clinician scientist at University Health Network.
Thank you. Andres Finzi.
So, hi, I'm professor at Université de Montréal. My lab is at the Centre de Recherche du CHUM, and I work on enveloped glycoproteins from HIV and SARS-CoV-2.
Thank you. Gemma Hopewell.
Hi, my name is Gemma Hopewell. I'm Professor of Precision Medicine and Epidemiology at the Nuffield Department of Population Health and the Big Data Institute at the University of Oxford over in the UK. So I'm a British Heart Foundation Fellow, and I've also been a visiting professor at the McGill Department of Human Genetics under the invitation of Professor Mark Laythorpe. I kind of lead a translational research program, typically in cardiovascular disease, focused on really big data approaches and that synergy between genetic epi and observational studies, and have been, as many people have, in the wake of the pandemic, those trained in epidemiology and big data have been involved in COVID-19 research efforts and several numerous panels such as this, which is a great pleasure to be here today to think about biobank resources and what they can offer.
Thank you. Then I'll invite Margaret Kelly.
Yes, hi there. Thank you for inviting me to this meeting. I'm a professor at the Cummings School of Medicine, University of Calgary. I'm an anatomical pathologist. I'm also a clinician scientist, and my research is focused on pulmonary pathology, asthma, fibrosis, and I'm also, as a pathologist, I'm part of the Alberta Health Services, and the division within that is the Alberta Precision Labs. Thank you.
Thank you. Antoine Lewin.
Lewin, you will be fine.
Okay.
Hi, my name is Antoine Lewin. I'm an epidemiologist and biostatistician at Québec, which is a provincial blood bank who play an important role in COVID-19 pandemic research initiatives.
Thank you. And our last panel member, Vincent Moser. Vincent.
Yes, thanks, Simon. Thanks for the organizers for inviting me. Thanks for RQCP to organize this meeting. And great thank you to the panelists here from different places who accepted to join us. It's great. I'm a physician scientist. My day job is I hold what is called the Canada Excellence Research Chair in Genomic Medicine since August 2019. My moonlighting job is I'm the director of the COVID Biobank in Quebec.
Thank you all. So now let's get right to it. Our main course is what role could be played by biobank in the pandemic, and in particular, looking into our interaction with public health agencies. So we'll not go in the full reverse order, but we will start with Vincent. If you have slides that you want to show, there's no problem. Martin, peux-tu permettre le partage d'écran? You just use share screen, and you can show your slides as you wish. If for some of you who sent your slides don't have access to them, just notify me a few minutes in advance so I can retrieve them.
Okay, thanks, Simon. Can you see my slides?
Yes.
Okay. I wanted to make a joke and say in the next 20 minutes, I will present the biobank, but I won't do this joke. Sorry, Simon. 5 minutes, promise. So the biobank is actually a mandate that we received from the Quebec and federal government on March 19th, 2020. At that time, we are 11 days after WHO declared COVID as a pandemic. We had almost no patients in the province, but really Carole Jabet, Rémi Quirion, others were seeing here a need for an infrastructure to support research in order to identify determinants of COVID-19 susceptibility, severity, and outcome. And in that way, contribute to public health response to the COVID pandemic. The task force, including several people here and Simon in particular, was assembled in 2 days. And we collaboratively designed the experiment in 10 days. We designed it as a prospective study with serial measurements over a 2-year period. And it's an observational study with extensive data in blood. It's multicentric with 5 Quebec universities contributing with 9 centers. We decided to have a broad range of disease severity from asymptomatic to severely ill patients. We decided as well to have a case control design with people, cases being SARS-CoV-2 PCR positive and controls PCR negative. We wanted to make it collaborative with national and international collaborations with CONCOV, Angela Chung here, the COVID-19 Host Genome Initiative, and others. And we wanted to obey to the open science principles. We put in place a governance, including an international SAB. We put the basics for recruitment in 10 days, which I think deserves probably a medal here. To follow what Dr. Merson was saying this morning, we used the ISARIC-based questionnaire. It's been extremely helpful, and we have really benefited from ISARIC and the groundwork done by them, so that we could start recruitment 10 days after that. And as per today, we have 3,500 participants with 2 visits in average, so 8,000 visits. We're collecting also multi-omic profiling on 2,000 samples, and we have completed whole genome sequencing at the Genome Center here at McGill for 2,500 participants. We have a process in place for researchers to access data. We have had 3 data releases, and 150 researchers have sort of asked or benefited from this data. We have contributed so far to 13 publications, and we have collaborations in place nationally and internationally. Just one piece of data we contribute to. We are not leading that. We contribute to the Host Genome Initiative. You may have seen the results of these large multinational GWAS analysis showing peaks here on this Manhattan plot, including the one on chromosome 12, which is a locus encoding for an enzyme called OAS1. And Brent Richards here at the Jewish General Hospital, who is in charge of genomics and collaborations for the biobank, and his team has been looking very carefully at OAS1 and demonstrated by combining genomic and proteomic analysis the protective properties of these particular isoform, making it a potential target for treating or preventing COVID. So I missed this one here. It's an important one, is the 3 data releases. We had 3 releases here. The dates are shown on the second column. The type of data are next. The format here, the number of patients, the number of samples in the data set, the size of the files, and the data provider. In essence, we have all the genome sequencing data available for the community. We have proteomics data available for the community as well for 2,000 samples out of 1,000 patients. And we are on the verge of releasing also additional data, including transcriptomics, and soon, hopefully, metabolomics. Thank you for your attention.
Thank you, Vincent. That was perfect timing. We'll now move to Gemma Hopewell.
Can we see the screen properly?
We're seeing your presenter's view. Yeah, that's perfect.
Is it perfect?
Yep, now it's perfect.
Okay, fantastic. So just speaking very briefly to kind of how biobanks can respond to public health needs in the context of a pandemic. Firstly, great to hear the work that's been coming on in Canada, and we know that several thousand biobanks have been supporting that global healthcare response. So really have to congratulate, from a researcher's perspective, those all around the world that have been involved in rapid data collection. It's emerged from these efforts and been really essential to our understanding of COVID-19 to date. Just to emphasize that the following slides really represent personal opinion. So I can't help in thinking about this question, thinking about opening remarks and considering the questions of how biobanks contribute. I'm going to obviously be thinking about the reflections on UK Biobank coming from my home nation. This is a biobank, as you'll all know, of about 500,000 individuals of middle age, and has really provided a fantastic resource for all researchers pre and post-pandemic. UK Biobank, in my opinion, taken very swift strides to help tackle this global pandemic by undertaking a number of major initiatives. That's ranged from studies of serology, of imaging, antibodies, infection, alongside rapid access to health record linkage data, including testing data from our Public Health England resources, and many aspects that were not previously part of the UK Biobank resource. Moreover, as well as being able to rapidly recruit into these studies, their model's really been extremely efficient in provision of data to the research community, which has been essential, obviously, for providing access and the impact on public health that's necessary. I mean, a good reflection of this is over 670 or so research groups have accessed the COVID-19 data in UK Biobank, and about 200 papers of COVID-19 related research have been published based on a wealth of observational and genetic insights. But if we think about how that's been managed, well, it's really in the thinking about that example, we need to think about this reflects many years of prior investment and underlying infrastructure, as well as the data sharing systems that already existed. So it's been enabled by preparation. The genetic data, the biomarker data, the original imaging data, already available, provided an essential backbone really to leveraging insights into COVID-19 by the research population. And that linkage to healthcare records has really ensured longer term health complications of COVID-19 can be explored in due course at the primary care, the secondary care, and the mortality level. So not just thinking short term, but also thinking long term about how this might work. And furthermore, there's been kind of recent advances in data access platforms that are going to really support the needs of researchers such as myself to make large scale multidimensional research data available. So thinking about that example and kind of thinking more generally now in terms of enabling and accelerating COVID-19 research and strategies for biobanks and priorities not just for biobanks, but researchers and for public health. Personally, I think it's important to consider what questions might be conceivably answered to ensure that any biobank that's being used by researchers or being generated in this pandemic or the next is fit for its purpose. So we really need to be considering what will be needed and why it's needed, so that we can avoid overcomplicating data collections, but make sure we collect the essential components. We don't want to have unnecessary delays or poor recruitment because we're overcomplicating things. We've also got to balance that short-term and long-term strategy. And it's quite important to think about how that can be achieved and what we can't achieve from any particular data collection. Obviously, infrastructure preparation, absolutely key to ensuring what we can learn from the current pandemic and enabling capacity for high quality research in biobank resources for the future. So we need to think now about how we would be better prepared for next time around, as well as capitalising on making sure information is available to date. Phenotyping in any disease, a massive priority. Ensuring comprehensive and robust phenotyping via record linkage and so forth is pivotal. It's imperative to avoid potential biases in research that can lead to incorrect conclusions. I think that has been difficult in COVID in some ways. And this also reflects documentation needs, also being key to ensuring data users understand what data can and cannot achieve. So when we think about examples of that, we can think about, can we differentiate between those that are hospitalized that have COVID-19 versus those that are hospitalized due to COVID-19? These are nuances that often pass by people and need good documentation to be able to compare different systems and healthcare systems across the world. Scalable data systems for large-scale data collection, sample processing, and long-term storage. Obviously, if public health is to benefit from a well-informed and timely evidence, then that's streamlined and democratic data access. Some of the concepts that Vincent was mentioning, really important to the research community. We need to avoid unnecessary hurdles in all areas of data collection and provision to the research community to enable those public health inferences. And also just thinking about future proofing. So not just what might be the questions of today, but what are the questions of tomorrow? That ensures that we can capitalize on the investments that are already made, and that longer term questions around disease can be explored robustly. So we have to think about things like long COVID and the general implications for longer term health. And finally, I think we need excellent communication and engagement pathways with the public and the research community. And it's really kind of through international coordinated activity with the global scientific community that we can achieve this. And some of the registries of biobank resources have been a really helpful starting point for researchers that are interested in various questions. So these kind of collation of information have been really important. So I'll leave those concepts with you for food for thought for the discussion.
Thank you very much, Emma. That last slide, I think, is spot on topic and probably something we'll want to revisit. We'll now move to Margaret Kelly. Please don't forget to unmute yourself.
Trying to get my screen share to work. I think I'm going to stop share and then just get it to work first. Oh, no, probably better to do it this way. Is that okay?
Yeah, that's perfect. Thank you.
All right, thank you. Yes, so thank you again for inviting me at this to come to this meeting. As I mentioned, I'm University of Calgary, but also Alberta Precision Laboratories. This is an entity that was formed a few years ago. We used to have separate pathology laboratories in Calgary and Edmonton, but when Alberta Health Services became province-wide, the pathology labs all joined up and now we're one big happy family, not always so happy. As you can imagine, it's a huge entity and everybody has to work along, get along together. But the advantage of it is that we are one big provincial body, and it's actually, you know, really good for research, in fact, because you know there's common protocols between all the different sites and the hospitals. So Alberta Precision Labs Just a little bit about it, 5,000 plus staff. We've done over 5.5 million COVID tests. There's many clinical trials underway, 62.8 million lab tests so far completed. There's 157 lab testing sites in Alberta, and it's just one lab system. So back in March 2020, when at the beginning of the pandemic, APL developed an Alberta-wide COVID-19 biorepository containing lab data and biological specimens. We did this by collecting remnant samples, so leftovers from specimens submitted for diagnostic purposes after completion of diagnostic workup. And this included blood, urine, tissue, including mostly formalin-fixed paraffin-embedded blocks of tissue and nasal swabs. These samples are collected for logistical reasons and then discarded based on type. So blood is kept for a short period of time until you know the test has worked and you don't have to repeat it, or that could be archived for decades based on regulatory standards such as our tissue blocks, which is common to all pathology labs. We didn't really have much funding. We got 300,000 from health trusts, mainly to buy some freezers. I was approached to write a CFI application by Dr. Galley, and the university allowed it to go forward, but unfortunately it was unsuccessful. So we don't really have any more funding than what we've got there. And in fact, the whole biobank has been, the lab technologists are actually doing all the work of collecting the samples and biobanking them. So it's a huge amount of extra work for the technologists to do. Sample store to date, in Calgary, we've had over 17,000 specimens and 24,000 in Edmonton, aliquoted and stored, combined total of more than 50,000 unique sample types. There's over 142,000 nasopharyngeal and throat swabs. Throat samples positive for COVID-19 have been collected by the Public Health Laboratory. Public Health Laboratory is separate to APL, but we collaborate closely with them. In March 2021, because of the enormous amount of work this was, we stopped collecting new samples, except the nasopharyngeal and throat swabs are still collected, but we're obviously still storing all the samples. And utilization hasn't been that great. We've only had 9 projects have requested samples, and mainly for method development. And that's where we sit at the moment. Thank you.
Thank you very much. It's important to see what's going on in different places. It helps us see different perspectives. And now I will invite Angela Chong to talk to us.
Great. I'm not going to use slides. I am just going to tell you a little bit from my perspective. So I'm a clinician scientist, and I actually do outcomes research and look at epidemiologic stuff as well as health services research stuff and some translational studies. So what happened at the beginning of the pandemic, I was looking after acutely ill COVID patients and also following them. And so in March, I remember having many late night meetings with Vincent and others on can we harmonize in terms of what we're collecting. So I am a co-lead of CanCOV. So that's the Canadian COVID-19 prospective study that is an observational platform study that was funded by CIHR. And I'm also a co-PI on the U of T, University of Toronto COVID Biobank. And that one was funded by a CFI grant. But that one got funded quite late, even though we started working on it quite early, since sort of March of 2020. So for the CanCOV study, because it's a platform observational study where we are collecting very granular data on outcomes, short and long-term outcomes of patients with COVID-19 across Canada, in many different provinces. We have 18 centers in British Columbia, Manitoba, Alberta, Ontario, and Quebec. We follow patients at baseline 7 days a month, 3 months, 6 months, and 12 months. And we have actually been conducting some 18-month follow-ups as well. It is across the severity of illness spectrum. So we look at both the non-hospitalized patients and hospitalized patients, both in the acute care unit as well as in the ICU. And we have been sort of looking at the outcomes of caregivers as well. So because we want to decrease the burden to patients, what we did establish was a platform where it's very patient-centered, and we're collecting clinical as well as research data and biospecimens. And that is the CANCOF study. What we have been doing, so at the very beginning, my institution, University Health Network, put some funds in to establish a institutional biobank, which is Preserve. But there was limited funds, so it closed sometime sort of this past year. And what happened is that we partner with them in terms of collecting inpatient sort of specimens. And currently there's a U of T biobank, which is involving multiple hospitals in Ontario. So that's sort of where things are at. And I can say that certainly learned a lot in terms of what works and what doesn't work, and how to establish networks across the country. I think one of the advantages of what I was able to do was prior networks of research. In terms of, because I did, 5-year outcomes in ARDS with my co-lead partner in CANCOF, Dr. Margaret Herridge. We pulled together networks from the ICU, critical care networks, and the internal medicine, general internal medicine networks across the country. And so CANCOF actually involved more than 100 investigators, basic scientists, translational, and genetics and multi-omic sort of researchers as well. Certainly learned a lot, and certainly Vincent can speak to the many late night conversations in March, talking about harmonization across these platforms.
Thank you very much, Angela. And I think a theme that appears to be coming, at least from our 3 prior presenters, is also the importance of pre-existing infrastructures or networks in supporting the response. We'll now move to Andres Finzi.
Can you hear me?
Yes.
Excellent. So I will do, I also have a 4-slide presentation. I hope I don't speak too fast. I just want to say, I guess I love biobanks. I would like to advocate about rapid access to samples, because this is critical in the moment of trying to inform public health. So for us, the most complicated thing to do was to get the first samples, because we needed to, in March 2020, we needed to build all the assays to measure serological responses. And actually, the first sample we got was our top sample, our worst sample. We have nothing else. So it was incredibly useful to have rapid access. I like to highlight a few. I selected some of the paper from the labs saying how having access to rapid sample, we believe, was helpful to public health, at least to some extent in Quebec. So by any work done in close collaboration with Quebec and the Laboratoire Santé Publique du Québec, we were able to get cross-sectional samples to develop pretty much every single assay and follow humoral responses. We followed that immediately with a cohort that we put here in CRCHUM to follow how the antibodies develop following infection. That followed another study led by Quebec, which was particularly important for the convalescent plasma trials that were going on to try to understand when is a good time. But for that, I insist, you need to have immediate access to the samples to develop some of the assays. And then, of course, we were interested in how this deneutralization response that was important, we thought it was important for convalescent plasma efficacy, how it's modulated. So at the same time, this rapid access to sample that was very important for the Laboratoire Santé Publique du Québec, led by Michel Roger, to actually kind of validate the assays that will be deployed in the province of Quebec. So you need to have access to, so again, and I'm advocate to having rapid access to samples. And this also led us to develop several assays that we can use to for serological purposes, but also help get a result in the recent published pan-Canadian Concord trial led by Philippe Bégin and Dr. Arnold at McMaster. We, of course, all and everything that we are doing is from this rapid access sample. I'm showing here how we together with Daniel Kaufman, we have been following the humoral serum response over time in infected individuals. And then also all the assays that we developed help to get the first story saying that about hybrid immunity, how people were infected and followed by vaccination got these good immune responses. Of course, we keep following on vaccine responses, and we are informing about all our results to public health authorities in Quebec and Canada. And of course, we publish all of that on preprint platform as well. And then, of course, what they do like the most, having rapid access to sample led us to develop some of this fancy stuff about trying to understand conformational transition between the spike and show the importance of the different part of the antibodies in protection in vivo models. We keep following some structural models. Some of the antibodies that we actually pull out from having this rapid access are now in a cocktail in a clinical trial. The idea will be to get this material back to show when these antibodies actually were elicited. And we're also finding how trying to again, this rapid access to sample led us to understand how the temperature is affected to some extent, at least the affinity of the receptor for the spike for its receptor, and also what are the different contributions of the single mutation that are rising a variant of concern. I think this is it. I guess what I would like to, this is just some of the work that we have been doing in collaboration with people here in Quebec and elsewhere. And I'd like to highlight that actually something that was very critical and is a study that was led by Antoine Lewin here from ECMA Quebec, that when we got the first sample to validate the assay, Quebec need to know what is the seroprevalence of COVID in the country. And I don't know if Antoine will speak, hopefully he will. And he actually provided the first report that was relayed to authorities on August the 5th, 2020, is the first in Canada. And so rapid, I mean, I think there are two, I see the biobank as serving two purposes for public health. One, you need rapid to develop the assays, and that's extremely important. And then you have the other one, which is large données for future generation, where you're going to be able to get this amazing and more complicated answer question, immunological question, other things that will be helpful for everybody. But we are still in the pandemic. I think that rapid access is the key word for me. Thanks.
Thank you, Andres. I think it's important to illustrate what can be done and some of the important barriers. So how do we conjugate rapid access with biobank? I think it's certainly a very important point of discussion, and seeing the output shows us or gives us motivation to achieve that. And it's a really nice segue into our last presentation with Antoine Lewin from Immaculée.
Hi, thank you. So I will share my screen. Okay, so today I will try to show you the contribution of our plasma sample biobank to the use of public health response in the COVID-19 pandemic. Quebec, just for your information that I think you all are already aware, but Quebec is the blood bank in the province of Quebec. So since the beginning of the pandemic, Québec was involved in the research initiative, and we have collaborated with provincial and national healthcare network by conducting several studies, notably the SARS-CoV-2 cerebral studies using blood donors. And the plasma sample biobank and the study are rising for it. It's a continuation of this collaboration with which we facilitated the conduct of study on the progression of COVID-19 pandemic amid mass vaccination. For example, we have conducted the third phase of seroprevalence studies using the plasma donor biobank samples. And as a blood bank, we have the unique opportunity to collect frequent plasma donor that enables the use of longitudinal study designed to understand the immunity of the COVID-19 disease. The sample that we collect enable us to gather information before and after vaccination, and in some other cases before and after COVID-19 infection. And also in other cases, this could allow us to observe before without infection or vaccination, and this will improve on the understanding of how vaccination or infection impact on the progression of the pandemic. And this project was funded by the COVID-19 Immunity Task Force. So presently, what we are doing, we are collecting plasma sample in 10 blood or plasma donor center all across the province of Quebec since April 2021. And after 5 months, we have collected more than 60,000 plasma samples from more than 12,000 donors, and which more than 5,000 donors have made more than 3 donations, including 1 pre-vaccination. And the acceptance rate for this project is up to 90%. And the biobank sample is open to other projects related to COVID-19 pandemic. The data that we routinely collect come from 2 different sources. The first is an internal data collection based on the medical questionnaire, which we routinely collect among others the demographic, the ethnicity, the height, weight, the medical use, the history of blood pressure, diabetes profile and treatment, COVID-19 vaccination status, the type of vaccine received, the number of shots, the vaccine date, history of PCR detected infection and PCR date. We also collect laboratory tests like blood type, ABO, RH, genotype, and phenotype. And we also have included in our biobank the ministry data, such as the infection and vaccination registry. We allow us to confirm the COVID-19 vaccination status, the type of vaccine received, the number of shots, the vaccine date, the history of PCR detected infection, and PCR date. The advantage of collaborating with blood bank, we think that blood bank are ideal partner to set up a project because of their infrastructure. We routinely collect blood sample all across the province. We also have scientific and laboratory expertise, and we have access to healthy population which adequately represent the general adult population of Quebecers and Canadians. And we also are aware of the need and restrictions that we may face. The recruitment and follow-up are also greatly facilitated to compare it to traditional enrollment of participants. However, there is some barrier, challenge, and limitation, and given the fact that there is a pandemic, there is a urgent, like Dr. Finley says, there is a urgent need to set up the biobank and start collecting samples before mass vaccination. This was at the beginning difficult to set up a biobank quickly and anticipate the elements to be considered for future studies that have not been yet defined. And this is also difficult for public health agencies to anticipate their need, such as what we want to collect, plasma versus cells. Seroprevalence data were used to forecast model for transmission of COVID-19 in the province of Quebec, and the results had to be generated quickly to rapidly inform public health measures. There is challenging to publicize the initiative to researchers and other stakeholders in the health network who might be interested in the sample and data of our plasma donor biobank. And as a blood bank, we need external funding because this is not in our core business. And there is also a need of collaboration and representativeness of different actors, such as the government and the ethical committee, which would benefit for our biobank and so prevalence studies. So this is it. Thank you.
Thank you, Antoine. I think we see that from this presentation and the different presentation, there's no one biobank to rule them all, but that different biobanks can work together to provide a much bigger picture. And that might be a way to achieve the different scientific and public health objectives. So I'll thank all our panelists. I think this was an excellent opening session, raising key questions. Now, what we will do, we'll move in this open discussion mode. So I will invite participants to ask questions by raising their hands. I'll remind everyone to ideally stay close to the topic so that, which is the role of biobanks in the public health during a pandemic and in helping public health agency respond to that pandemic. Questions could also be coming from panelists if you wish so. I'll give priority initially to the audience, but the second order will be panelists. And if there's a long silence, instead of doing what I usually do with students and just wait, and I tell them I can be very patient, then I will redirect the conversation instead if no one wants to bring anything to the table. So the floor is open for discussion. Margaret.
Hi, yes, thank you. Those are just amazing presentations. I'm just so impressed what you're doing in Quebec, actually. It's just incredible. I wanted also, the biobank, this is serum from people who are donating blood, right? They're not coming in just donating for the purposes of the biobank. You're collecting the serum from volunteers donating blood.
Yeah, that's correct. And we have a focus on plasma sample. So this is only donors that came to give plasma donation, apheresis plasma donation. Yeah.
So you won't really have follow-up of these people, but you will, you brought up a really important point that you're collecting serum before vaccination. Hopefully everybody's going to be vaccinated soon, so we won't be able to see this again.
We do have a follow-up because we have more than, to date, we have more than 5,000 frequent donors that gave more than 3 times with at least one donation before vaccination. So, right. And you can give at least once a week plasma. So, we have
do you have good access to all their health data as well?
Yeah. Yeah, we routinely collect the demographic information, like I mentioned. I do not highlight all the information we collect, but we also have information using the ministry registry, like vaccination and infection. So we can have access to the infection observed by the public health ministry and the vaccination date and etc. and the type of vaccine.
Okay.
Thank you. I see a question from Patrick Blondin. You can unmute and open your camera if you wish.
Thank you, merci. Hi, everyone. Thank you very much for this very interesting workshop. I just joined Génome Québec recently, and getting more and more informed on these biobanks, and I've been kind of following it from the sideline. And before I joined Génome Québec, so I guess the question is, I was thinking, where are we going in the near future, and maybe a little further beyond in terms of requirements for collections? I saw, Vincent, in your presentation, you're talking about 2,000 samples. Are we being asked by provincial and federal governments to keep adding to these banks? From research, I can imagine how that would be very important, but I'd like to hear from this group in terms of what are going to be our needs in the future, and what could we be doing more in terms of collecting samples and maybe tests and any analysis that need to be done. So we want to try to project for our needs that are going to be upcoming in the next year or two.
Thank you. Excellent question. I think that everyone around the panel may want to contribute to this. So who wants to start first? Vincent?
Maybe I can start, and thank you, Patrick, for your question. I think you're raising here an important question, which I hope, Simon, you will maybe elaborate later, is the sustainability of biobanks, because Patrick is asking what's next. And the question is absolutely spot on. We need to anticipate what will be the needs of the community as well, the research community, the public health agencies as well, in terms of data and samples. So I think sustainability is important. Margaret, you were so kind to share with us as well the fact that it has been difficult to raise funding for the sustainability of your Alberta biobank, which is potentially really important, but exploiting it fully requires resources, vision, commitment from agencies, and I think that's a topic which probably each of us shall address. I think, Gemma, we are all jealous when we see the UK Biobank. We're even asking ourselves, is there a room for us when we're seeing such a wonderful infrastructure? Very briefly also, I think the point that Dr. Merson was making this morning, which is exactly what Andres was talking now also and others, is a network trust between investigators, between people, so that if something happens, a new pandemic, we're all ready to jump. I hope that the COVID has taught us something in this direction and established maybe the solid network, so that next time, I hope it will not happen. We have had these discussions with Angela, with Andres, with Margaret, with Antoine, and with JQ and UK Biobank. We are ready.
Thank you, Angela.
I just want to say that the biobank in Quebec has been very successful. Congratulations. Like Margaret, I think it is tricky to sort of look for infrastructure and funding to support across the country. But I think it's so important that it is actually across the country, in the sense that genetics may be different, ethnic composition may be different. So thinking about the EDI, sort of equity, diversity, inclusion issues in Canada right now, it is so important to really try to have infrastructure for across the country, so that different people can be recruited from different ethnic backgrounds as well. One of the things that when I was listening to Antoine's presentation that came to mind is I actually am a co-investigator for the support study. Support is also funded by CIHR. It's actually something that was added to CANPATH, CANPATH, led by Dr. Philip Awadala. This is sort of a population epidemiologic kind of study, and what they did was added a component for biospecimen. And so did the Canadian CLSA, so the Canada Longitudinal Study in Aging. When we think about sort of biospecimens, we really should sort of look across sort of where things are, and how we can, like my study, the CANCOV study, only includes COVID patients. There are no controls. And so it is important to look across to understand, to answer different questions. Anyway, I just want to make those points. One is on the EDI, equity, diversity, inclusion issue across the country. And two is it is important to harness existing infrastructure for whether it's the HEMA Quebec or across the country, or CanPath or other sort of epidemiologic studies.
Thank you. Gemma?
I'd really like to echo Angela's thoughts. I mean, I'm particularly an advocate of kind of thinking about the larger biobanks and thinking about how actually we can synergize and create a better response by enabling a large national infrastructures that effectively you can do small sub-studies within, rather than necessarily focusing on reactionist small specific studies. And I wonder actually different members of the panel how they feel about that balance, and what we could learn from different countries around the world, and how that balance has worked or not worked so well in different domains.
Thank you. So if I understand this correctly, you're interested in us addressing whether the importance of those large studies versus the, let's say, the more smaller or investigator or disease-driven collection in answering these challenges?
Yeah, I mean, when we think about something like the UK Biobank, it's not perfect by any means. You know, there are pros and cons to everything, but it's been able to leverage insights into COVID-19 quickly because it's been able to use its infrastructure to do sub-studies. So it's effectively some of the sentiments that Angela was talking about. However, a lot of the individuals, a lot of nations across the world have done small specific studies that effectively lots of lessons will be learned, but whether we should be able to synergize on that in a different way, so that actually that investment is well placed and that it's investment for the future, not just for the present. You can see my slant on it. That's a bit biased.
Thank you. So we'll take that question, but just before we move on to that question, I just want to check if either Antoine, Margaret, or Andres wanted to comment on Patrick's point of what's going on, and then we'll come back to that related point at the same time. Otherwise, I'm going to forget. And
I mean, if I can, for me, I just like to, we are still in a pandemic, right? And I think that the rapid access to sample is something that is important. There is a lot of question that we still don't understand, and I would like to stress that. The other thing related to the question that Vincent was putting out as creating a network of a lot of the work that we did, we put our own code here because we couldn't have access. We were very lucky to be able to work with LSPQ and to EMA Quebec, but it was, we need to have this rapid access that we couldn't have otherwise, but for these two institutions. The other thing that is very important to synergize samples is how the samples were collected, and how uniform. If someone is trying to look at PBMCs and trying to look at cellular responses, are we looking at the same response depending on how these samples were processed? Can we do this analysis or not? And it seems, I think that's something that is very important. I know the BQC has a very good and robust way to doing that, but I don't know how all the other biobanking are working related to that. And something I should like to point out about the importance of Antoine's EMA Quebec's biobank. We should get a paper related looking at long interval between short interval. We couldn't have access to short interval in Quebec, but for them, and with this sample, we are able to address that question and showing how the long interval may have some benefits. So, and I would like to highlight and congratulate that for the rapid access to that. From the time I'd requested, I mean, it was in a Friday, and I got the sample, I think the next Friday, 7 days. MTA put in place ethics and everything. So kudos, guys, because now we are able, it's not only about the paper being accepted or not. I know the public health is waiting for these responses. So we could get this rapid access. And I guess I'm here as an advocate of rapid access. I guess that's pretty much it. Whatever I'm gonna say is related to that.
We're gonna call you Andres Rapid Access Finzi now. Okay, so Angela, you wanted to come back, and Margaret, as I promised, I said, Margaret first, you could answer the first question, and then we can go, Angela, to Gemma's question, and after that, we'll do a follow-up on Andres' question, and if I can remember all of that, I'll be quite proud of myself. Margaret.
Sorry, it's not a question, it's just to say, I think with the question of EDI, I think the remnant samples are good in that, although you know, certain populations don't have access to healthcare, at least, you know, when they do, we have been collecting samples, you know, without any bias, obviously, because I think people who will volunteer to give blood are probably people who are not in these marginalized areas. So I think the remnant samples is really a fantastic idea because of that. But the problem, of course, is that many researchers said, no, we want fresh samples. We have to go and get our own patients and consent them to give us some fresh blood, because we need 30 mils of fresh blood, and our remnant samples won't do that for them. So that was a drawback. Could I just ask, and the other problem we had is ethics. Our ethics are very slow and very admin heavy here. We could never get anything done within a week. When we had the first the SARS outbreak a few years ago, it took 6 weeks to get ethics to respond to us, and meanwhile we were trying to get blood and tissues from people with SARS. So that's a huge issue for us here, and I'm very impressed with a week in Quebec. My other question, my question, sorry, I did have a question, was how difficult is it to get patients to consent to come and give their samples? Is this a barrier to doing these biobanks when it's on a volunteer basis like this? Thanks.
Thank you. Angela, do you want to answer with Gemma's point? And we can also, if you want to provide information to Margaret's point as well, that's welcome like everyone else afterwards.
I think Margaret's point may be better answered by Vincent. But I want to say that I want to get back to Margaret's point on ethics and contracts and everything else. Like, this is one of the things that I really sort of look at the UK, and Gemma, maybe the UK Biobank is not perfect, but the UK system of how we can get things through fast is something that I sort of am very I look at it and think, Canada can do better. Each province has its provincial boards. Each institution has its own board, and you have to go through multiple levels. And then there's contracts. And so, why are we repeating 40 times the same thing? If we can actually get something that is a bit more up top and say, okay, this is approved by the committee, and it should be approved by every single institution, whether it's a community institution or a academic institution across Canada. So I think those are some of the big barriers because it wastes a lot of money and people's time. It's not that simple for us to get a sample to you, Andre, because you have to, there's so many layers. And I'm hoping that that can actually be improved going forward. And how can we sort of, so for the CANCOF consent, it has to be listed on the consent form where we're sending samples to. We try to be as broad as possible, but our ethics board is very particular. Like, if I want to send something to the UK, I would have problems. So that's something that I think we really need to work on. I just want to answer Gemma's one point about small groups and studies and investigators. I think those are really important as well. But what we don't want is really a siloed system. So like all these lots of little investigators applying for support. And we are burdening the patient. If there's things that we can share, and if there are ways that we can reduce the burden to the patients, that will increase the yield, cost effectiveness. So this is my other hat around sort of the economics of all of this, right? It's much more cost effective when we actually can have many things happening. So like one tube of sample, but split 5 aliquots to 5 different researchers. And if we can use the same data, and yes, I understand depending on how it's processed and stuff like that, things may not be comparable. That's why the harmonization is so important.
Thank you, Angela. And I'll just echo your comments on the contracts. At times in the last 18 months, I thought I was doing a sabbatical in law more than anything else. Andres, you had
Yeah, so I agree with what Angela say. I mean, I understand about the contract and I understand all of that. But if we get the samples in 2023, and remember, this is COVID-19. So we need to get, I mean, trying to optimize the serological assay later on, it depends which level you're trying to address. Very sophisticated immunological question. This is, again, large données, this is for future generation, is gold. But for informing public health immediately, you need to get that going. Something that I've been in other committees and always floating the idea, because I'm virologist, fully not objective here. We need the Canadian Institute of Virology. So I don't have postdoc processing blood. There is an institution coordinating that, fully agree, with normalized assay from east to west of Canada to get that. And then I have all the other roadblocks about provincial and national and all of that. But it would be great to have something that people need to have rapid access. If not, you cannot help. You cannot help public health. You just can't, not now.
Thank you. I see that our legal and ethics expert at McGill and at the BQC19, Manzawati, has his hand raised. I don't know if it's a question or comments on the topic, so I'll welcome him to the floor.
Thank you, Simon, and thank you, everyone. I think, I mean, I'm hearing echoes of really kind of lengthy process and journey when it comes to finalizing these discussions and putting in together the process and contract and so on. But I do think that the issue, in all honesty, is one of model. And probably something to think about in the future around the funding model for these projects. Currently, biobanks for most of the times are considered as projects, and they're projects where the funding is managed by institutions, and generally speaking, either a hospital or a university. So in any way, shape, or form, the functioning around the biobank, including its funding, but also access to the data and samples, are intrinsically linked with the entrenched sort of process of that institution. There are some institutions that have the necessary expertise to make this happen in a very, quick way, but there are many institutions that don't have that, whether it's at the contracts office, whether it's at the ethics committee. I'm called, in different institutions, how do we deal with these clauses? What does that mean? And so on. So I think, in the future, one way to, especially in cases like this, where in a pandemic, probably the funding model would be, it would come with either funding for the proper expertise, or potentially seeing the biobank as an institution or an entity in itself that is going to be able independently to deal with its contracting issues. And because it might work for one institution, but most likely won't be the same for others, even if you use the same model, because of the resources that are available. The other point that I wanted to make, which is a very important one, and I think it was mentioned by Dr. Chung, regarding consent and sending samples, and that is a big issue. But I think also it is really important for researchers to make it very clear to the Research Ethics Board and the groups that there are two different ways of sending data and samples. There's one that includes storage and future use, and one which is sending for access purposes that comes with contracts and TAs and so on. And they seem to be much more open to sending when it comes to access. So we store the data and samples and we send them when there's an access request, versus sending it so that it could be stored elsewhere in another country for future access requests. And I think making that distinction is very important. Thank you.
Thank you, Man. Any thoughts or follow-up, Vincent?
Yes, two points. Firstly, things look maybe very glossy and nice on slides. That means it looks like it was easy. It was horribly difficult. And when I'm listening to Andres' rapid access Finzi, I can tell you how frustrated we were having an expert like Andres and having the samples to wait until all the contracts were in place. I hope that if it happens again, we will be much faster. And despite all the efforts, we can be quicker. Just want to answer also a point I think that Margaret was raising about participation rate. Participation rate was dependent on different on disease severity, location. But I think the most important thing was really trained personnel to collect the consent, explain the study, and all that stuff. And that is awfully expensive. Angela was raising the issue of cost and effectiveness. All these efforts have been very, very expensive, in my opinion. But also that's probably the price to pay for having high quality samples properly consented and all the system in place, which enables sharing. The very final point, I think Gemma's slide on the criteria for a sustainable and successful biobank were spot on and very inspiring and very sort of educational for us.
Thank you, Vincent. Angela?
I just want to comment on sort of the privacy and the confidentiality issues in Canada. So I've been sort of here working for the last like 25, 30 years, and I can tell that things have really been moving closer to what the EU is doing in terms of privacy. And so even though, you know, a sample may not be linked to PHI, in terms of, you know, it may be a sample number with some details. And nowadays, people are very concerned, and even if you are sending it for testing, you know, a specific third party, whatever, like, you know, me sending to Andres for testing of something. It is very, it's getting more and more difficult, I find. And somehow we need to figure out a way to sort of make it a bit easier, because something like that, I understand the concern. The concern is, well, the biosample, somehow someone can do DNA on and sort of, you know, have knowledge of, you know, and link to other things. But it is, I work with people in Denmark and in other places, and I have to say that Canada, in terms of privacy and confidentiality, is kind of moving that way. And we need to strike a balance between these issues and public health, you know, urgency, as Andres has highlighted.
Thank you, Margaret.
Yeah, I just want to comment. So we did have a meeting with a patient representation group just to let them know that we're keeping these samples. We've got ethics approval and all that, but we wanted to have a patient-focused, just because of all the issues around this. And this group were very positive that they want their samples to be collected for the good of going forward for health purposes. They don't care who gets the samples as long as somebody uses them and they can be used towards progress. They were very concerned, though, how can we make sure that the researchers who are getting these samples are sticking to what they're supposed to do and not doing something extra, which is hard to answer them, apart from just telling the researchers you have to sign and say you're going to behave yourself. They were concerned about that, but they were very positive that we should collect the sample. So that was encouraging. But the privacy thing is just really crazy, in my opinion. We have this wonderful electronic healthcare system in Alberta called Netcare, and it's wonderful for me as a pathologist. I can look up the patient's radiology, their serology, everything that I need to know to help me make a diagnosis. But Netcare is not allowed to be used by researchers. So you're not allowed, even if you've got ethical approval from the patient to look at their healthcare records, to go through everything for the purposes of research, we still have to physically get that healthcare record out and go through it. We're not allowed to log into Netcare for the purposes of research. And that was put in place long ago when Netcare was first put in place, because people are very worried that, you know, it's very easy to click on somebody's number in Netcare and look at all their history. But even when the patient and or the subject says, you're welcome to go and look at anything, we're not allowed to do it. And Netcare would make our lives so much easier as researchers if we had access to this record.
Thank you. One thing I hear in this last part of the conversation is this idea. So patients are quite willing, I think, when we explain to them what we're going to do, but there is also a general worry of what can be done with that information. And so certainly something we've seen, certainly across the world, is this the dialogue between the science and the population. And maybe we have, I guess my question to the panel would be, are there things we could be doing better in engaging the general population to help them support these initiatives? Because if we're going to these ideas of having sustainability structures, infrastructure that are invested, and being able to move with less paperwork, I think we'll need to have popular support that can pressure some of the organization or the ministry, the government agencies in helping this. Gemma?
Yeah, I think these are all kind of issues not in Canada, but across the world. So I don't think anybody's alone here. I do think most of the things that I'm hearing, at least, really are about preparedness and foreseeing what policy changes could happen at a high level and what effectively could be done on the back end of knowing what went wrong with COVID-19 and in terms of, Netcare. Why? Is there a real reason, or is it just politics? In which case, then this is a good reason and a good time to be pushing on those doors and forcing those windows open to try and ensure that what is possible can become more possible. Because actually that's what will create ease for the future, in my opinion. And that's what enables the harmonization to a greater extent as well. If everyone's working together to similar standards, to similar data access standards, to the data provision standards, then researchers are happy, the public is happy, and public health is unhappy.
Thank you. Angela?
So historically, Canada healthcare system is province-based. So it's a distributed system, and each province can decide what they want to do. And so in the research realm, so in Ontario is similar to Alberta, in the sense that even as a researcher, whether even patients have actually consented to give us stuff, we cannot use Connecting Ontario, which is the sort of the system where I can look up, for clinical care, I can look up whatever. But even when patient has consented, we're not allowed to go to that system to look for stuff, which really increases the complexity, right, to collect data as well.
You realize I'm being extremely optimistic and simplistic in the viewpoint, but it just seems that all the government level and regional level scenarios effectively should now be held responsible by the public to some extent for putting barriers in the way that don't need to be there. And then maybe we can ask questions now more. I don't know if that's true in Canada as well, about how that can work better for the future. With an open, honest spirit of what would have happened in COVID-19, maybe 6 months earlier, maybe, that's unrealistic, but months earlier. How realistic do you think it is in Canada?
I'm certainly hoping to see a conversation around this, and CIHR has been engaged with this. One of our co-investigators in CanCoff, Francois Lamontagne from Sherbrooke, has actually written a piece of all the barriers to research in Canada, and how we can do better. Because across the board, I think the researchers and scientists are quite collaborative compared to other countries. So even when even when there is collaboration across the scientists and physicians and researchers, the issue is really trying to cross all those barriers. And Vincent was talking about it's not an easy journey, even though it looks great on a slide. I can't tell you how many I have weekly meetings with my contracts people to move things forward. I have weekly meetings with my ethics people. So I think some of those things are can definitely go smoother. With all the checks and balances in place, right? So, I mean, I am totally for ethical research and want to respect privacy and confidentiality of our patients because they entrust us with these samples. But I think then we should work on a better way.
Thank you. There was a request by Margaret. If you can share this article with the group, it would be appreciated, unless the barriers are too heavy and the file is too big, so it cannot be shared. But I'll assume that once they're digitalized, it's okay. I think we'll do a slight redirect here because there was a couple points that were, I think at least twice, the engagement of users came up as a barrier. Having the resource and not enough users. And I'm responsible in part for the access at the BQC19, and that would be my nightmare scenario as well. All this time, effort, investment, sitting in the freezers, that would be a poor return. So I'd be curious to hear the panel's view on how we can enable access. Obviously, there's, I think, one of the obvious thing is all the paperwork that could be streamlined, but one question would be, are there other strategies to engage the community? We have this meeting, this 2 days meeting, I think from the RQCP, which is a great opportunity to get researchers around and then listen to what's available. But anything else that the panel members can see? I think, Margaret, you've raised your end.
No, sorry, I didn't raise
Okay.
my hand. Sorry.
So anyone wants to talk about engaging?
I mean, I'm wondering what will be the answer if you do a poll to all the people from the BQC19, right? What do they think the people should do with their samples related? What's the goal? How many hurdles need to have to give that to researchers to inform? I think that from anecdotal discussion with the nurses in the court here, what they want, actually the patients are frustrated that sometimes they are keeping asking for addendum because what they want, they give the blood because they want this to move forward. So I'm wondering whether if you poll them to all the users that, I don't know if you can because of but if somehow someone will be able to have a poll about what the people want when to provide blood for biobanking to a particular disease or something that we do with that. And I think that they will say rapid access and move research forward. And I understand some of these important ethicals. I'm going to tell you that we got rapid access with all ethics. It's doable. It's complicated, but it's doable. So again, anecdotal examples, but I wish there is a poll saying what people will want us to do with the material, biological material that they're providing is to advance research. I mean, I bet it is the case.
Nice,
Yeah, it's really important what you're saying. I think we also need to make sure that it takes time. When I was listening to Dr. Merson this morning about ISARIC, they have now also an access committee in place. We can request data from ISARIC. They have not had that many publications yet, just because it takes time. UK Biobank, Gemma, please correct me, but I was listening to Naomi Allen, I think day before yesterday or sometime recently, and she was saying that I think, if I remember well, UK Biobank has contributed to 200 publications on COVID. So what, are there any requests for samples as well? What type of analysis have been done? And I also remember you telling us that you did a lot of work actually cleaning up the database as well to make it essentially very useful. Can you comment on these points?
Yeah, sure. Yeah, based on our searches as well, it's about 200 COVID-19 related publications from Biobank at the moment. Bearing in mind that there are a lot of registered researchers already. So I do think inevitably that timeline was somewhat speeded up by effectively, again, the infrastructure and the preparedness that was already there. Sorry, your second point of your question?
Maybe you have an answer to what Andres was saying as well. So have there been any requests for samples, and what are people wanting to do with the samples? So
that I can't comment on. I'm not a UK Biobank employee, so I don't have any privy information to what they are receiving in terms of those requests. Inevitably, there's always a balance between ensuring that we can do things in a timely fashion as researchers and ensuring best use of sample. And I think that's always something that as scientists we have to appreciate when you are using a bigger biobank resource as well, effectively where it's not just for COVID-19. COVID-19 is a subsidy. What biobank has done is, of course, initiate its own rapid response studies in terms of the serology, the infection sub-studies. They were recruited into very quickly, again, because they're recall of original patients and their families. So that's enabled some streamlining, which wouldn't happen if you were trying to set up that serology study or something in a in a new population of people. One thing that actually I almost came across in scouting the internet, as you do, was this registry of biobanks that have COVID-19 related samples and data. Maybe everyone's very familiar with it, but it was something that was new to me. And it lists a vast number of collections that have got relatively small numbers of samples in some of them, but relatively specific and very important samples, and those that have kind of got more epidemiological level insights. But those kind of registries must be very important for people that are looking for niche areas. So the internet is a great tool for doing that as well.
Thank you. Andres?
Yeah, thanks. I like to talk to a point raised by Vincent. Again, rapid access, happy to stick with that nickname. The point being here, I say advancing research informing public health. So when Antoine and Emma Quebec produced the research of the first seroprevalence study, they didn't publish it. They sent it to the authority. That was the first thing. It took time. So but if we go, so I try to make the point not about publishing, which is of course important for academics, but I'm going to shy away from that. But if we talk about publications, the longest, because it's fierce. The competition is just fierce. I'm coming from the HIV field. I thought it was hard competition. Well, nothing compared to what it is right now. And time is critical. So if someone want to address the role of the different isotypes in neutralization in people who have been acutely ill, and they get the samples next month, well, they can publish Journal de Montréal, because everything has been published already. So depending where you want to use the biobanking to position the research, because the biobanking is for advanced public health, advancing research, informing public health. But if you want to use this as a leverage for the faculty or the academic community in a given place, the low-hanging fruits are the easiest taken, right? The first gone. And then the most complicated one will only be addressed with these unique samples and capacity, etc. That's fine. But so there's also a balance there. So if we go, I try to avoid publication, even though I put the papers just to highlight some of the paper we did, how I thought were connected. But my point is that, again, rapid access is important for also from the academic to keep the network of researchers alive and being present. Again, too late an access, a lot of questions that would have been addressed if we had the access has been done by other groups. So we can do confirmatory studies. But is this what we are aspiring when you have this amazing biobank there to confirm what every other people have been doing? I mean, I think it's important. It's important to confirm. But perhaps you could do better.
Thank you. As we're moving in the last minutes, so I'll almost going to do a wrap up, but I'll give Antoine a chance to comment on any of the things that may have been said before I do the wrap up. And after that, I'll ask each of panelists to come up with 1 or 2 words. I have a pretty good feeling which are going to be Andres' 2 words that may be summing up anything that we've discussed today. But before that, Antoine, do you want to comment on any elements?
No, I just want to say that I completely agree with Andres, and we strongly want to give a rapid access to other times. That's why we have that's why in my presentation I say that responsiveness to the stakeholder are really important, like public health or any participants that are involved in the project, and we strongly benefit from that with the registry of the ministries that we have had access to, and this was very important for us, and this is what we want to build as quick as we have done our biobank, and not only for publishing, like Andres said, but also to inform public health. This is really what we want to do, And this is the aim of our biobank finally.
Thank you. So I've tried to take a few mental notes as we were to the different talks and what we've been discussing in the last hour and a half. And first, I want to thank all of you, the panelists, those that have attended, those that will be listening to this at a future time. So thank you for listening to it in the future. That's a bit weird. I'm talking to the future. Anyway, so what did I remember? One thing, I think it was in Gemma's presentation, she talked about preparation. And I think this is a key for most, any endeavors, anyone who's doing sporting activities, you know, it's the training that will deliver on the day. In the case of a pandemic, we don't know when that day is. And I think that puts even more emphasis on, you know, making sure that we keep being prepared. What does preparation means in the context of biobanks? I think you've raised a different number of points. Using established networks, developing infrastructure, working on making less hurdles in terms of administration. What could we do ahead of time in negotiations to open pipelines that may be open all the time, and some of them may be just in the case of sanitary emergencies. So where are the boundaries to that? Lobbying. I'm thinking that scientists weren't always the best at lobbying, but we maybe need to engage more the politicians. We have a great opportunity with the pandemic of being at the forefront more than usual. So it may be a time to get those politicians listening to us, and also the public. I think public confidence is really important, and keeping an open discussion with them, both for engagements in biobanks, but also for the overall support to pressure on the politicians. Obviously, sustainability will be an issue, the funding. So maybe these preparation and the steps we've said would be important. And I think this was top of my head, but I remember from the last hour, there's a lot more, but thankfully we have a recording of it. But now I will go around the table to ask for your 1 or 2 words that you want to say as your closing remark. Vincent?
Rapid access. Sorry, thank you. I'm actually amazed by the convergence here. Of course, we are preaching to a choir, but it's maybe a request, maybe Simon, is there any maybe way to write up some proceedings of these discussions and have the panelists maybe to contribute to that? Because again, we are talking to each other, we know what we're saying, but outside, I think there is room. We have wonderful success stories, we have more complicated stories to share, and I would strongly push towards this direction, of course, if you were to agree.
Yeah, this is just very quickly. First, the RQCP will provide, I think they plan on providing kind of a write-up, but something we've kind of preemptively discussed with Vincent is the possibility, based on that write-up, to put something together that we could share with the panel and then use it as one of those steps of talking to the greater communities. So if you are interested, let either me, Vincent know, and we will take this forward. So Vincent, what were these your 2 words? Okay, Angela?
So I have 2 points. One is it's not just rapid access, but it's the ability to do rapid knowledge to action. So I think, around the table here, different people sit at different national tables to try to do that piece. Is really, can we turn the results into action so that we can really help the public health response. So that's my 1 point. The second point is, and I think those tables are really important, and it's more important than publications in a pandemic per se. And we have been doing that with CanCov and my other study. So the second point is EDI. It's really important to figure out how. So Margaret has a good way of having residual samples, but outside of that, how can we actually make sure that racialized communities are included? Because traditionally they may be more hesitant and also have more doubts about participating in research or in biobanks or other things. So those are my 2 points. Thank you. Thanks for including me.
Gemma?
I'll say making biobanks fit for purpose So preparedness of infrastructure, engagement pathways, and in true international style, international cooperation and collaboration. And thank you very much for having me.
Thank you, Margaret.
Yes, my thoughts are, what can we do to improve the status? Is there any way we can get someone to lobby the federal government? And obviously in Alberta, we should lobby our provincial government to make it easier to access, for rapid access and for funding. Yeah. My other thought on that was patients, if the public is behind us, we could do anything. In Alberta, we've recently got My Health Records. Patients wanted access to their health records. So now there's a special app you can download and you can look up your results in the privacy of your home, which I don't think is a wonderful idea if you're looking at a pathology report that tells you you've got a malignant tumor, but that's what the public wanted and they've got it. So maybe we need to get the public behind us.
Thank you. Antoine?
I think an important point could be the awareness of what is done and what data are collected to avoid duplication and to allow a better orientation of research initiative and research questions that we can have and questioning the data that we need. So an awareness of all of this collected and what study are performed. It's important, I think.
Well, thank you very much. Thanks to everyone, and I'll leave the last two words to Andres. Andres.
Yeah, thank you. So I want to say I fully agree with Angela. This is not about publication. It's about informing public health in the context of a pandemic. If you do not have rapid access to sample and data, there is no way you can generate data to inform anybody. So I insist, it's not about publication, but there is so many things that could be leveraged by that. So yes, I end up with, without rapid access, we have a problem to inform public health, independently of publications.
Thank you very much. Thank you for your participation. Thank you, everyone, and enjoy the rest of the meeting. I think there's the Assemblée Générale du RQCP this afternoon. Bye-bye.
Thank you. Bye.